So in this session, I'm going to start off by talking, as John said, about the interferons in myeloproliferative neoplasms. This is a drug which is not licensed for use in these diseases. And the outline of the talk, for which I have 20 minutes and 20 slides, is as follows. I'll try and define what the interferons are, or what interferon is. I'll talk very briefly about the broader clinical uses of interferons, because there's some interest, and it's mainly historical, but I think it's important to mention. And then I'll focus on the use of interferon in myeloproliferative neoplasms. So interferons are proteins which are found in all of our bodies. They're in very, very small concentration in our bloodstream. And in fact, it's interferon that actually makes us feel like we have the flu when we have the flu. So the effects biologically of these proteins, the interferons, are very wide-reaching, and I'll mention some of them. But what we feel when we have high levels of interferon in our blood is that we have the flu. So we have muscle aches, headaches, pain, fatigue. We don't feel good, crummy. And I'll mention this again. There are a few different types of interferons. It gets very confusing, but we'll be focusing on one group over here. So there's type 1, type 2, and type 3 interferons. And they all come from different cells. So usually the type 1 interferons are produced by cells in our body that have been infected by a virus. So that's what I was alluding to when I said that when we have the flu, we get infected with a virus. We feel the chills, the muscle aches, the bone pain. We're feeling that because the virally infected cells are secreting the interferons. Now, again, the type 1 interferons, and this is important, are divided into alpha and beta interferons. They're also known as viral interferons because of the stimulation by viral infection. And we'll come back to alpha and beta again. Gamma is the appellation that we give to type 2 interferon. This is also called immune interferon because this is an interferon that's produced by our immune cells, specifically a type of cell called natural killer cells, after these cells are exposed to an antigen, to some foreign object, which these cells mount an immune response against and produce gamma interferon. It's less important for our topic today. And type 3 interferons are also called gamma, type 1, type 2, and type 3. But these are irrelevant to our discussion. I just mentioned these for completeness sake. This is a newly described and classified group of interferons. We're going to go back and have a look at the type 1 interferons, which are of clinical relevance to us. How do they work? Just briefly, this is the same schema that I showed this morning with the JAK-STAT pathway. Interferons bind to an interferon receptor. There are many interferon receptors. It's a very complex biological model. We can see here alpha and beta interferons. So this would be examples of the type 1 interferons, alpha and beta. And their signal transduction, it's the same concept, just using different molecules, starts out by a more complex, it's not so simple as it was with the JAK2. Here we have JAK1, we have TYK2, and a variety of other proteins which are activated, phosphorylated. The phosphor group is placed onto these inert molecules to make them active, and then the intracellular signal transduction, or the talking between molecules, occurs in the cytoplasm of the cell. And we have again here STAT1, another group of proteins, the ISGF proteins, and they tend to form complexes, and then the complexes enter the nucleus, attach to specific areas of DNA, which are called interferon responsive elements, and they generate a signal within the nucleus of the cell which causes this particular host cell to respond, to divide, and to carry out a cellular function. So the overall model is the same. The binding of a ligand or a chemical or a cytokine, in this case it's interferon, to its specific receptor, the induction or initiation of cell transduction, which is the intracellular conversation that goes on between molecules, which ultimately stimulates an effect in the nucleus of the cell, which is what causes that cell's response. A fairly uniform kind of mechanism that we have biologically. So a couple of slides now with long lists, which are deliberately long, just to make the point that lots of things happen in each one of these slides. So what are the effects of interferon, the biological effects? So it's a long list, and it's meant to be long. They induce the pro-apoptotic genes. In other words, they induce cells' death wish or their death mechanism and cause cells to die. They modify the microenvironment around cells, and specifically around cells in the bone marrow. They inhibit angiogenesis, which is new blood vessel formation, which is critical for tumor growth and development and metastasis. So you could see why this might be a good drug to use in a cancer setting. They inhibit specifically tumor cell growth in various tumors. They promote cycling of the stem cells, that very, very early cell in the bone marrow where all the trouble starts. And they suppress the proliferation of early progenitor cells in the bone marrow. And they modulate the host immune response. They do just about everything that you could think of biologically that would be relative to the, not initiation necessarily, but the progression, development of a tumor of one of a variety of sorts. So interferons would be a very interesting target to study biologically, to understand tumor growth and development. And if they would be used therapeutically, they may have many, many different effects on the individual. And so it's not surprising that interferons historically have been used, again, another long list deliberately, and this is not an exhaustive list. Fortunately, almost all of these diseases that appear on the slide over here, and I won't read them all out, now have more specific targeted drugs which are more effective than interferon. But interferon has been used in all of these drugs. All the type 1 alpha and beta interferons, save multiple sclerosis, which the interferon, which is still in clinical use, there is a gamma interferon. But for all the rest, and including viral infections, hepatitis B, hepatitis C, and there's more to add to this list, but I didn't want to make it too long. But you can see the same way that interferon has a lot of different biological activities, so too it's been found to be useful in a number of different tumors, very, very different tumors over here. Some are blood tumors, some are solid blood tumors, and some are solid tumors with no relation to hematology at all. Again, it's been phased out gradually, tumor by tumor, simply because more effective treatment has been introduced. Now let's look at the specific types of interferon that are in clinical practice. And again, here, there's a list, and there are a number of them. So there's interferon alpha, 2A and 2B. These are the older forms of interferon, the native drug, so to speak. These have trade names, of course. These drugs, as we'll mention soon, have toxicities that are associated with them. They need to be injected under the skin. They need to be injected on a daily basis or on almost a daily basis, certainly a number of times a week. And along came a technology called pegylation, using a molecule called polyethylene glycol, which is linked to the interferon molecule. And this has the effect of causing a very slow release from the tissues into the bloodstream of the interferon, of the drug itself, which allows weekly, 2-weekly, maybe even 3-weekly dosing of the drug, and potentially can reduce side effects of interferon. And this is the drug that is typically used today. And again, there's pegylated interferon alpha 2A and 2B should appear here as well. The drugs are known as Pegasus and Pegintron. The pegylation molecule, polyethylene glycol, is non-toxic, so it can be safely used. And this has been revolutionary in the treatment of diseases that are responsive to interferon. Finally, there's a new formulation of pegylated interferon called Ropeginterferon. This is a novel pegylation technology that allows even less frequent dosing and potentially can improve the side effect profile of the drug. So we've mentioned side effects a few times because that really is the limiting factor with the use of interferon. And as I mentioned, interferon is what is in our blood in excess when we feel like we have the flu, because we have the flu. So the first side effect of this drug will be the whole range of flu-like symptoms, which I think we've all experienced firsthand, even if we haven't received interferon injections. Then there are very troubling neuropsychiatric side effects that can develop in people that use interferon, ranging from depression to psychosis. Autoimmune phenomena. Autoimmune diseases are those in which the immune system, rather than producing antibodies or an attack mechanism against a foreign invader, much like in football, the system scores an own goal and inverts itself and starts attacking tissues of the organism itself. So there are a lot of autoimmune phenomena that are associated with interferon use, ranging from thyroid disease to alopecia to skin disorders, kidney disorders, all on an autoimmune basis. As we said, this drug has a lot of different mechanisms of action, so we can see over here its potential to cause a lot of harm in a lot of different ways as well. Liver toxicity, lung toxicity, peripheral nerve toxicity, the list goes on. And this results in approximately 25% of people receiving interferon having to stop the drug. And this is probably a dose-related and a duration of treatment-related phenomenon. So if you give enough interferon for long enough, you will probably reach a toxicity threshold which will not be tolerable for most people. The introduction of PEG interferon is probably responsible for a reduction in the side effects that people experience when taking interferon, although this is not universally agreed upon, but certainly it has the potential to reduce interferon toxicity. Interferon has been used in myeloproliferative neoplasms for more than 30 years, all of them, myelofibrosis, PV, ET, and clinical responses certainly do occur, but it's difficult to use this drug because of the side effects, and we'll see some of them soon, especially myelofibrosis, where it has been tried many years ago, and it was not successful in that context, and so it was abandoned by most people in the field. Not only does it improve the clinical features of the disease, but it also has the potential to improve biological features of the disease, and in particular, if one does serial bone marrow biopsies in patients with fibrosis in the bone marrow, one can observe a reduction in the amount of fibrosis in bone marrow on people that are receiving interferon. This represents, of course, a true biological effect of the drug. And in the current era where we can monitor people with mutations, the driver mutations in particular, we can see that people who have mutations have either a reduced allele burden or disappearance of the mutation in a significant number of people, but this is not a consistent finding in all patients nor in all studies. I'd like to focus a little on polycythemia vera because there are studies ongoing that have been completed in polycythemia vera, and in 3 small phase 2 studies in PV, we have results that have been reported for the pegylated and for the new Ropeg formulation of interferon. I'll jump ahead of those phase 2 studies in the interest of time and talk about the phase 3 studies, which follow on the phase 2 studies. These are randomized comparative studies between 2 groups of patients. This one is conducted by the MPD Research Consortium, number 112. Number 111 was the phase 2 study. And this looks at pegylated interferon versus hydroxyurea for people with both PV or ET. And here the patients need to be high risk, and the asterisk there tells you what a high-risk patient is. And they either have to be newly diagnosed, relatively newly diagnosed, or have had no prior treatment. So hydroxyurea is compared over here to the pegylated interferon at a dose range that you can see appears there in the micrograms per week dosage. And after 1 year, investigators performed an initial analysis, which has been presented. And we have over here the PV and ET patients together, and below we have simply the PV subset, but the numbers are fairly constant. And if we look at the overall response rate, which is what's in this column over here, for hydroxyurea, 39 patients who completed the first year, we can see a response rate of 69% for hydroxyurea, 70% if we just look at the PV patients, up to 81%. So there's more patients responding to the pegylated interferon in both PV and ET, and in the PV group alone. This did not reach statistical significance. The p-value over here is not significant. Looking at side effects or the adverse events recorded in this trial, not surprisingly, there were more recorded in the PEG interferon group versus the hydroxyurea group. Some of these reached statistical significance. The more severe, the grade 3 adverse events were more frequent in the interferon group than the hydroxyurea group. And again, it's things that we've mentioned: depression, fatigue, flu-like symptoms. These are of importance. So the message from this study is that the drug is as effective as hydroxyurea in terms of hematological responses, associated with more side effects. But the important caveat is that this study is far from over, and it is evolving, and we'll have to see how results look in a number of years' time. I want to jump back to a phase 2 study just to show you. This is one of the first reports of the Ropeg interferon alpha, called AOP 2014. This is a single-arm study, which has now gone on quite a long follow-up, up to 5 years. And this is hematologic responses, and you can see that all hematologic responses included, we get almost 100% response. But it takes a long time. This is a week scale over here, and you can see that some patients who did not respond initially continue to climb up on this curve over here, and we can have responses more than a year out. So that's encouraging, and we need to be patient, and that reminds us to be patient with the MPD consortium study as well. And what's even more interesting here is we look at the change of JAK2 allele burden, we can see over here that in almost all patients there is an improvement. This is called a waterfall plot. And as the lines get shorter and shorter, you can see patients that have responses. But there are responses to JAK2 in terms of measurement of the JAK2 allele burden in the majority of patients. So there is a hint over here that there's something real biological that's occurring. And this has given rise to a phase 3 study, which has an initial phase and a prolonged phase. It's called the PROUD and CONTI study, CONTI for continuation. And here we have new patients who have either received short-term hydroxyurea and didn't respond, or have not received any treatment at all, who are randomized to either receive this new formulation of interferon, Ropeginterferon, or hydroxyurea. There's a 12-month analysis, and then there's going to be a follow-up analysis in the continuation study. And they were trying to look at, as a primary outcome, the results in terms of efficacy to show that the Ropeginterferon is no worse than hydroxyurea at 12 months, and to look at specifically the hematological responses. And here we have this 12-month analysis. We have two sets of analysis. This is what the patients, as the treatment was planned for them, and this is the patients that actually received the drug, the per protocol results, and the results are very similar. This very significant p-value over here means that non-inferiority was proven. So Ropeginterferon is not inferior to hydroxyurea in terms of achieving a normal blood count. Of interest is the side effect panel, and here we can see something that's a little different from what we saw in the first PEG interferon study that I showed you. And I think what's notable over here is the significant amount of toxicity that was reported for the hydroxyurea patients. And here we can see that the numbers are flipped. If before the hydroxyurea looked better than PEG interferon in terms of side effects, here it's the reverse. The Ropeginterferon has less anemia associated, less leukopenia, less thrombocytopenia, less nausea, the same amount of fatigue, and a liver enzyme increase, which is of laboratory interest only. So I think this is a very interesting thing to take note of. We may have a drug over here that's actually better tolerated than hydroxyurea. And that's pretty much what they summarized over here, that both drugs can achieve hematologic control. We knew that about hydroxyurea. We now know about the interferon formulation as well. And this particular form of interferon actually is better tolerated than hydroxyurea. This is just to show you that there are a number of studies that are ongoing with the Ropeginterferon, with ruxolitinib combined with PEG interferon. Some of them take low-risk polycythemia vera patients. Some take high-risk or resistant polycythemia vera patients. So we're going to be hearing a lot more about the results of these trials in years to come. And there's a certain sense of renaissance when it comes to talking about interferon in the treatment of myeloproliferative neoplasms, and in particular polycythemia vera. How might one use this drug, just to conclude? Well, it could be used early on to achieve blood count control, to perhaps address the splenomegaly issue if the speen's not too massive. I didn't mention it, but there's a lot of data suggesting that interferon actually reduces thrombosis risk, which, as we spoke about this morning, is very important in polycythemia vera. It may have some late benefits as well. It may reduce the size of the clone, and it, in fact, may reduce the amount of fibrosis that is present in the bone marrow or retard its progression. One would consider using interferon in certain patients. Patients have to have a certain disease, a certain level of performance status with not too many comorbidities. Other organ function has to be fairly intact. This is a toxic agent one way or another. Might be better tolerated early on in the course. I didn't mention the fact that certain studies have indicated that if you have some of the passenger mutations, the other mutations that we mentioned this morning, such as ASXL1, EZH2, that may augur not well for these patients. They may respond more poorly to interferon. Younger patients may tolerate the drug better. It's useful in pregnancy. And there are certainly limitations. We know about the short-term negative impact on quality of life. We don't know how tolerable these drugs, particularly the Ropeginterferon, would be for the long term. And then we're going to have to wait for the results of these randomized trials to actually see how this drug, particularly the Ropeg and the other PEG interferons, will perform against hydroxyurea in critical randomized trials. Thank you very much.